All right, let's get right into it. We're talking about a complete game changer in how doctors treat one of the biggest, scariest things in medicine, a pulmonary embolism, or PE. The brand new 2026 guidelines from the American Heart Association, well, they're not just a small update. They are a massive shift from what was basically blunt force medicine to a whole new world of precision care.
I want you to picture this. It's 3 in the morning in the ER. A patient gets wheeled in, they can barely breathe, clutching their chest. You race them to a CT scanner and yep, there it is, a big blood clot sitting in their lung. You know, for years, what happened next was kind of chaotic. We used these really clunky, confusing terms like massive PE, which, okay, sounds terrifying, and submassive PE, which, let's be honest, sounds more like a sandwich order gone wrong than a life-threatening condition.
And that kind of ambiguity, it could be deadly, which is exactly why these new guidelines are such a big deal. This isn't just about tweaking the old rules. No, this is a complete teardown and rebuild of the entire approach. It's a whole new way of thinking, moving away from a one-size-fits-all playbook to a strategy that is super specific to each individual patient.
So the heart of the problem was that old word submassive. It didn't do its job. It made it sound like the situation wasn't that bad, but in reality, that patient's heart could be on the verge of giving out. It was dangerously vague, and it led to doctors all over the country treating the same problem in wildly different ways. So the number one mission of these new guidelines is to fix that, to create one single unified language for everybody.
And this slide really nails the change. We are completely tossing out those old vague terms. And in their place, we're putting in a much more detailed, much more precise A through E classification system. The goal here is simple, but it's incredibly important. When an ER doc, a cardiologist, and a surgeon are all talking about the same patient, they're all speaking the exact same language and visualizing the exact same level of risk. No more getting lost in translation when a life is on the line.
So what is this new system exactly? Well, the best way to think about it is as a spectrum of risk. It's like a journey that lets us pinpoint exactly where a patient is at any given moment, from totally fine to critically unstable.
Just imagine a color-coded warning system. Category A is a calm, cool green. These are patients who are actually safe to go home. As we move through B and C, the color starts to warm up, turning to an orange. But by the time we hit D and E, it's a blaring, flashing red. That's the signal that we need life support, and we need it right now. This clear progression from A to E is the new roadmap for PE care.
Okay, so let's actually walk through these zones because some of the most profound changes in how we practice medicine happen at the two extremes of this spectrum, with the safest patients and with the most critically ill.
Now this is what you could call a low-risk revolution. Take Category A patients. They're subclinical, which is just a fancy way of saying we found the clot by accident. Maybe they were in a car crash and we were scanning them for something else. They feel totally fine. Category B patients have symptoms, sure, but their vital signs are stable. Now, in the old days, both of these groups would have been admitted to the hospital, no questions asked. The new guideline says, firmly, send them home safely with a prescription for a blood thinner. And this isn't a guess. It's backed up by safety checklists, things like the PESI or HESTIA criteria, that give doctors the confidence to avoid a hospital stay that just isn't necessary.
Okay, now let's move into that more complicated orange zone, which is Category C. This is the intermediate risk group. To figure out if a patient belongs here, you're looking for two key signs. First, is the right side of the heart physically strained from that blockage? We call that RV dysfunction. And second, is the heart muscle so stressed out that it's leaking chemical distress signals into the blood? Those are the biomarkers, like troponin. C1 has neither. C2 has one or the other. But C3, which is the most dangerous of this group, has both. These are the patients who absolutely have to be in the hospital under very close watch.
And now we arrive at what is arguably the single most important concept in these entire new guidelines. It's something that defines the incredibly perilous Category D. It's called normotensive shock, and it shines a light on what might be the most dangerous misunderstanding in all of acute medicine.
This is the million-dollar question. Normotensive literally means normal blood pressure. Shock means the body's systems are failing and shutting down. I mean, to most of us, that sounds like a total contradiction. If the monitor says 120/80, the patient's fine, right? Well, that assumption, that very natural assumption, is exactly how patients can die unexpectedly.
The answer is simple and terrifying. The blood pressure cuff is lying to you. It's showing you an illusion. You see, the body is compensating like crazy. It's cranking down on blood vessels, making the heart race, all to keep that one number on the monitor looking pretty. But if you look deeper, the body is failing. You'll see their lactate levels are climbing, the patient is getting confused, and they stop making much urine. So the key takeaway here is that this patient might look stable, but they are standing on a cliff edge, just seconds away from a complete collapse.
So what do you do when you have a patient in one of these super high-risk categories, a C, D, or E? Who do you call? Well, the guidelines now formalize a concept that sounds a little bit like a medical superhero squad.
The old way of doing things was often a massive turf war. You'd have the ER doc, the cardiologist, the surgeon, and they might all have different ideas about the best way to proceed. And, as this quote just perfectly captures, while all of the specialists were arguing about who was in charge, the patient was getting sicker. All that time spent in friction is time lost, and that can kill patients. The solution is the PERT, the Pulmonary Embolism Response Team. It gets a Class 1 recommendation, which is the strongest endorsement you can get. It basically means you absolutely should be doing this for your high-risk patients. The PERT brings all the key specialists to the table at the same time. There are no turf wars. There's just a rapid group decision when every single second counts.
So, let's pull all this together. What does it all mean? Well, these guidelines really represent 4 fundamental shifts in how we think about and treat pulmonary embolism, moving us from a world of confusion to one of incredible precision.
So let's just quickly recap those 4 huge shifts. First, we've moved from total confusion to real clarity with a single standardized language. Second, we've gone from admit everyone to safely sending low-risk patients home to recover in their own beds. Third, and this is so important, we finally learned to unmask the silent killer of normotensive shock. And finally, we've replaced those dangerous turf wars with true teamwork through the PERT. Every single one of these changes directly translates into saving more lives.
And that brings us to our final thought for today. This whole concept of normotensive shock, this idea of a patient who looks perfectly fine on the monitor but is actually dying, it's really unsettling. And it forces us to ask a much bigger, more philosophical question that goes way beyond just PE. In what other areas of medicine, or even in our own lives, are we being fooled by normal numbers? Where else are we blindly trusting the monitor, totally unaware that we're standing right on a cliff edge? It's definitely something to think about.